So in 6 ASA grade, what are the, how do we classify the patient? ASA grade 1. In ASA grade 1 means patient has no systemic illness. We have already discussed so many times. Patient has no systemic illness. Okay. So patient has no systemic illness. This is ASA grade 1. Okay. ASA grade 2. Patient having systemic illness, but systemic illness is controlled. So patient having a controlled systemic illness. So mild to moderate systemic illness. Mild to moderate systemic illness, right? Mild to moderate systemic illness. Very good. Okay. ASA grade 3, it is moderate to severe. Moderate to severe systemic illness. ASA grade 4 is life-threatening. Life-threatening. So ASA grade 4 is life-threatening systemic illness. Okay. Okay, everyone. Uh, Pregnancy has been added. A normal pregnancy, because of the physiological changes of the pregnancy, is not in ASA grade 1, though pregnancy is a physiological thing, but because of the physiological changes of the pregnancy, it has been put in ASA grade 2. So remember that normal pregnancy normal pregnancy has been put in ASA grade 2, and even pregnancy with mild systemic illness is still in ASA grade 2. So normal pregnancy and pregnancy with mild systemic illness is still in ASA grade 2. Now, pregnancy with severe systemic illness is in ASA grade 3. So for ASA grade 3, we have pregnancy with severe systemic illness. Severe systemic illness. Right, severe systemic illness. Okay, so pregnancy with severe systemic illness is in ASA grade 3. Understood? Okay, everyone, obesity has also been added. Mild to moderate obesity is in ASA grade 2. So, obesity also here, mild to moderate obesity. Moderate obesity in ASA grade 2, and let's say morbid obesity. Morbid obesity is in ASA grade 3. So, two important things I have added for you. One is this pregnancy, normal pregnancy, and pregnancy with mild systemic illness is ASA grade 2, and pregnancy with severe systemic illness is ASA grade 3. Mild to moderate obesity is ASA grade 2, and morbid obesity is ASA grade 3. Okay. Apart from that, whatever we have discussed about ASA grading, we have to remember. Okay. So 1, 2, 3, 4, we know. No systemic illness, 1, mild to moderate systemic illness, 2, moderate to severe systemic illness, 3, and life-threatening systemic illness is 4. 5, you all know, is surgery is the only option for survival. Surgery is only option for survival, right? That is your ASA grade 5. And ASA grade 6 is comatose or brain dead patient, comatose patient. Now you can see this, that 1, 2, 3, 4 is a separate grading system, and 4, 5 is a 5, 6 is a separate grading system. 5 is separate, 6 is separate. So actually this is not a uniform grading system. The only uniformity in this grading system is that from ASA grade 1, 2, 3, 4, your risk associated with the surgery is increasing. That is risk of morbidity and mortality. So what is the answer? So put in the chat box. Yes, Anmol, Udish, put in the chat box. What will be the answer? We have already discussed. A 24 years old pregnant patient with no comorbidity, is what belongs to what ASA grade? So put in the chat box. She is ASA grade. She has no comorbidity. She is ASA grade 2. So for 1, the answer would be ASA grade 2. Yes, B is the answer. Everyone. So answer is ASA grade 2. So ASA grading is very important. It's one of the most important question of exam. And I'm somehow thinking that if they will expand their questions horizon in ASA grading, they can go on pregnancy and they can go on obesity, which has been added recently. Okay. Now next question. Next question is again on pre-anesthetic evaluation on nil per oral. So the question is that a 25 years old patient posted for upper limb surgery. Upper limb surgery, and this is planned under brachial plexus block. This is an elective surgery planned under brachial plexus block. Which is the correct statement regarding nil per oral order? So nil per oral, first of all, we have to know nil per oral is mandatory prior to any elective surgery, irrespective of type of anesthesia. Whether I'm going for brachial plexus block, whether I'm going for general anesthesia, whether I'm going for just a sedation, but nil per oral is mandatory. Nil per oral is mandatory. So remember, nil NPO is mandatory. Mandatory, and very good. Most of you are giving me the right answer. Mandatory, and but I will little bit twist the question and then I'll try to confuse you. Then let me see what you give me the answer. Okay. So NPO is mandatory for elective surgery, irrespective of type of anesthesia. And we all know for the NPO orders, we have remembered for the NPO orders 8, 6, 4, 2, right? So 2 hours NPO for clear fluid, And who will put in the chat box what do we mean by clear fluid? So can anyone tell me what do we mean by clear fluid? Shahil Khan, can you tell me? Or Alpha, can you tell me what do we mean by clear fluid? What do we mean by clear fluid? Does it, the clear fluid, does it involve only water or anything else? So water, of course, it is clear fluid, but fruit juice also, without any particulate is clear fluid. Then your tea, tea, coffee without milk is also clear fluid. And carbonated drinks are also clear fluid. And we encourage that patient should take in the clear fluid. In fact, today what we are asking, we are giving the patient the glucose water 2 hours prior to surgery, and changing the fasted state. We are trying to change the fasted to fed state. This is a new principle, fasted to fed state. Why fasted to fed state? Because this is something which is recommended in ERAS protocol. ERAS is enhanced recovery after surgery. ERAS means enhanced recovery after surgery. Now, what do I mean by enhanced recovery after surgery? This means that we are trying to make the recovery of the patient quicker after surgery and discharge the patient. So if the patient was NPO for very long hours, that was increasing the risk of nausea, vomiting in the patient. That was causing, let's say, more fluid to be given during surgery and anesthesia, and a lot of complication was happening because of that. But when we changed from fasted to fed state by promoting that patient should take as much clear fluid as possible 2 hours prior to surgery, the recovery became faster. So this was the question which was asked lately, that what is there in the ERAS protocol. One of the thing in ERAS protocol is that take as much as clear fluid possible 2 hours prior to surgery. Then 4 hours is for human milks. 4 hours NPO for human milk, right? Then 6 hours NPO for liquid and semi-solid diet, semi-solid food, and also for non-human milk, any non-human milk, any liquid or semi-solid. Okay, right? And 8 hours for full fatty meal, right? Now everyone, what we write in the pre-anesthetic order. In pre-anesthetic order, we write take light meal 6 hours prior to surgery. Take light meal 6 hours prior to surgery. So this is the order which we are writing. So what is correct regarding NPO order, and they're not mentioning type of food, then 6 would be the priority answer. If it was not 6 to 8 hours, it was only 6 hours and 8 hours separately. Like if it was 6 hours, it was 8 hours, it was 24 hours, it was 2 hours, like this, then I would have chosen the answer as 6 hours. If 6 is not there in the option, I would choose the second best is 8 hours, right? So 6 to 8 hours is what we have to remember, but 6 we will give priority. If they write a particular type of food, then according to this protocol, we have to follow. We have to follow according to this protocol. Clear fluid 2 hours, human milk 4 hours, 6 hours for light semi-solid light meal, non-human milk, and 8 hours for full fatty meal. Got it? So keep it in mind. Okay. So I hope you have understood. Everyone has understood, I presume. So can I go to the next question? Yeah, next question. Okay. Following graph is seen in patient under general anesthesia for laparoscopic cholecystectomy. What is the most probable diagnosis? So this is again one of the most commonly anticipated question, right? This is one question which I expect can be asked anytime. This is one of the commonest topic of the exam, all your exams. What is happening? Patient is undergoing laparoscopic cholecystectomy, right? Patient is undergoing laparoscopic cholecystectomy, and suddenly in the capno, we are getting this, right? So what has happened? The CO2 is decreasing. The CO2 is decreasing. So sudden, I always tell you, sudden drop of CO2. The blind answer for this case is embolism. Embolism. So guys, the answer has to be embolism. Very good. Right. Yeah, some of you has like in the chat box put the answer bronchospasm. Let me tell you the DD of rest as well, right? Now this is a very simple question because it's embolism only in which the fall of CO2 will be seen, and rest of the options increase in EtCO2 will be seen. Okay, in endobronchial intubation. So let me discuss endobronchial, bronchospasm, and malignant hypothermia and embolism as well. So, uh, embolism, what happens in embolism? What happens in your malignant hypothermia, intra-malignant hypothermia? What happens in bronchospasm? And what happens in endobronchial intubation? Endobronchial intubation. Endobronchial intubation means one of the bronchus, the tube has gone. So let's first talk about embolism. Now this is your alveoli, this is your alveoli, and these are the blood vessels surrounding the alveoli, okay? So what happens in these blood vessels? What happens? The embolus goes. So these spaces becomes a dead space. So the exchange of O2 CO2 drops. So in embolism, what will happen? There would be a sudden drop because these areas have become the dead space and no exchange is happening. So we see a sudden fall. We see a sudden fall, right? Okay. What will happen in malignant hypothermia? Malignant hypothermia is a perioperative complication in which the metabolism becomes hyper. This is a hyper metabolic state. And what is the metabolic byproduct? CO2. So what we will see, there would be a increase in the CO2, just opposite to what will happen in embolism. So doubling doubling or tripling of CO2, doubling or tripling of CO2. CO2 is suddenly increasing. Okay, so CO2 is increasing. This is malignant hyperthermia. Very important. This is malignant hyperthermia. Now, what will happen in bronchospasm? What will happen in bronchospasm? Now, this is your airway. This is your airway, and the spasm of the airway has happened. The spasm of the airway has happened, right? Whenever there is a partial obstruction, the natural caliber of the airway has reduced. What are the things we will get? Clinically, what we will see? Increased pressure, airway pressure, increased pressure in airway. Now, caliber decreases, the airway pressure increases, right? Then, because the caliber has reduced, there is some obstruction in passing out of the gases. So, flow of the gas is having a high resistance, the pressure increases. What happens? Saturation of the patient decreases. And what happens to the EtCO2? In EtCO2, what happens? That we get a shark fin pattern. We get a shark fin pattern. And the final, everyone, remember the numerical value of the EtCO2, which is demonstrated, is end-tidal CO2. This is the last end-tidal CO2. So that end-tidal CO2 will be higher in bronchospasm, that is partial obstruction. So EtCO2 will increase and the shape of the graph will change, shark fin, shark fin. And similar will be the presentation in COPD also, like as in bronchospasm, even in asthma. Anywhere the caliber of the airway has reduced, we will get this kind of presentation. Got it? So CO2 will increase in this case as well. Okay, then let's talk about endobronchial intubation. Now, what happens in endobronchial intubation? In endobronchial intubation, the tube has gone into one of the bronchus. So only one lung is getting ventilated. Ventilation is happening. Other lung, the ventilation is zero. So half the lung is only getting ventilated. So the surface area for the exchange of O2 and CO2 has become half, right? So what will happen? There will be a sudden, okay, decrease. Shouldn't write sudden. There will be a decrease in SaO2, that is saturation, and there will be an increase in EtCO2. What is the alveoli responsible for? O2 CO2 exchange, and the area for the O2 CO2 exchange has become half. So from blood, CO2 getting not exchanged at that particular rate, and O2 is not going into the blood at that particular rate because the surface area has become half. So saturation decreases and EtCO2 increases. So in one lung ventilation, when we do it for thoracic surgery, we have hypoxia and hypercapnia. We have hypoxia and hypercapnia. So here also the CO2 will increase. So if you see this, let's say question, in endobronchial intubation also EtCO2 is increasing. In bronchospasm also EtCO2 is increasing. In malignant hyperthermia also EtCO2 is increasing. So it is decreasing only in embolism. This is important. Remember where the EtCO2 will increase and what clinical condition EtCO2 will decrease. That will help you in solving your clinical questions. Got it? Everyone understood this? Everyone understood this? So can I move to the next question, I presume? Can I move to the next question? Yes? Okay, next question. Okay, so again, this is an expected question. This question has already been asked. I'm just repeating the question. Which of the following test is depicted in following image? So what test is being depicted in following image? So answer is, of course, Allen test. Yeah, this is Allen test. This is Allen test, isn't it? This is Allen test. Okay, everyone. What we do in Allen test? What we do in Allen test? Allen or modified Allen. Allen or modified Allen test. Right. In Allen or modified Allen test, we check the patency of the arterial arcade between radial and ulnar artery. This is done before cannulation of the radial artery. So this test, this is done before cannulating radial artery, right? This is done before cannulating radial artery. And then, guys, why do we do it? This is done to check patency of arterial arcade between radial and ulnar artery, right? Because once you cannulate the radial artery, this artery will go into spasm. We have to see the area supplied by the radial artery gets its blood from this arterial arcade, right? So we check it, and this is what is called Allen or modified Allen test. Okay, now very important, 2-3 more tests I'll tell you. Okay, guys, one is your Barbeau test. That is also done to check the patency between arterial arcade between radial and ulnar artery. The only difference is that in Allen test, we see the color of the palm has returned or not. In Barbeau test, we see the waveform of the pulse oximetry. And one more thing I want to say that The color of the palm on releasing the pressure from the artery should return the color of palm should return within should return within 1 to 3 seconds, right? 1 to 3 seconds, as fast as 1 to 3 seconds. If it is taking more than 6 7 seconds, then the arterial arcade is not good. Got my point? Now Barbeau test is a similar test. Barbeau test, in this, we see the waveform of pulse oximetry. It is Allen test. Someone has written in the chat box as well. Allen test with pulse oximetry. So Allen test with pulse oximetry. Pulse oximetry. And you know something? These doesn't have a very good accuracy, these tests. The best test to see the patency is Doppler ultrasonography, which we kind of do nowadays when we suspect there's any issues, right? So the most sensitive way to see the arterial arcade, is your Doppler ultrasonography. Doppler ultrasonography. It is Doppler ultrasonography. Got it? Remember, Doppler ultrasonography. Okay. So this was our fourth question. Okay. Now let's come on the next question. Now, the next question is on circuit. In this, I have asked Mapleson circuit used for pediatric anesthesia. Now, again, somehow my gut feeling, this question can come. And I have told you that there are 6 Mapleson circuits. And for adult, 2 important circuits in use is A and D for spontaneous and controlled. But for pediatric, there is only 1 circuit which we use for any type of ventilation. So for pediatric anesthesia, the answer has to be Mapleson F. And so many of you are answering. So I'm so happy. You have a good preparation, I presume. Right? So Mapleson F will be the answer. Mapleson F is also called Jackson-Rees circuit. Mapleson F, or it is also called Jackson-Rees circuit. Jackson-Rees circuit. Yes, Chitra, it is F, 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 F. As we always discuss, F, 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 F for pediatric. F, 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 F for pediatric. And F is modified Mapleson E, right? It is modified, F is modified Mapleson E, right? It is modified Mapleson E. All these are asked in exam, so I'm giving you, right? Okay, now very quickly, a quick revision, just 4 or 5 questions on the circuit, what I expect. Okay, 4 or 5 questions. First, we have 6 Mapleson circuits. Mapleson circuit, Mapleson A, B, C, and D. These are adult circuit, right? Then we have E and F. These are pediatric. And what do I mean by pediatric? Less than 6 years, less than 20 kg. Less than 6 years, less than 20 kg. Okay. Now let's talk about Mapleson A. Mapleson A is also called Magill circuit. It is also called Magill circuit. And this is best in adult for spontaneous ventilation. For spontaneous ventilation, this is the best circuit, right? And here, for spontaneous ventilation, we keep fresh gas flow equal to minute ventilation of the patient. So all are exam question. This is a Q, this is a Q, and this is a Q, right? B and C we are not using. B and C we are not using. D is Bain circuit, and this is best for controlled ventilation, right? And here we keep the fresh gas flow 1.5 to 1.8 times minute ventilation, right? So this is a Q, and I have not seen till now fresh gas flow of Bain circuit which has been asked. Okay, then guys, For spontaneous ventilation, I'm writing S for spontaneous. Spontaneous ventilation. The best is A followed by D followed by B equal to C. For controlled ventilation, the best is D followed by B equal to C followed by A. So remember, A is worst for controlled ventilation. So this is also a Q. Okay. Then Mapleson E. This is bagless and valveless. First pediatric circuit, bagless, valveless, and I told you I'm not writing it useless. This was made useful in the form of F. So guys, F is the Jackson-Rees modification of E, right? And this is the pediatric circuit of choice. Pediatric circuit of choice, right? So for pediatric anesthesia, this is the circuit which we are using for both spontaneous and controlled ventilation. Got it? These are things we know. Now I'm just going one step further. I don't expect this question to be asked, but just for a caution, I'm going one step further on images, guys. Now A stands for, A is for away. Now what does the circuit do? What does the circuit do? Circuit connect anesthesia machine. This is the anesthesia machine and the patient, right? So if the anesthesia machine and the patient end is away, if the patient end and anesthesia machine, this is the patient and this is the machine, they are away, then it is Mapleson A, right? Now if the let's say if the anesthesia machine, this is the anesthesia machine, this is anesthesia machine attachment end, and this is the patient attachment end, they are near, then it is D, right? So A is for away, A is for away. So A means away, anesthesia machine is away from patient, and in D, anesthesia machine and patient end is near. Now for E, so this is A, this is D. For pediatric E, it has no bag, no valve, like this, inverted T shape. It's called IR's T piece. No bag, no valve. This is the patient end, this is the machine end, right? And for F, we just in E, we have added a open bag, a bag with a opening. This becomes F. So guys, if image is asked, I have gone one step further. If image is asked, just for precaution, you have to remember this. Okay, everyone? Understood this? So this is all about your Mapleson circuit. Coming on the next question. Okay. Now they have not asked this device till now in exam, but in lot of questions I have seen this device as an option. So somehow I see the questions are formed from the option if a new question is formed. So this is one airway device which I want you people to remember. Now as it seems, it looks, this is a supraglottic airway device, isn't it? It won't go in the trachea. It should be above the glottic opening. So this is supraglottic airway device. Supraglottic airway device. Right, everyone? This is supraglottic airway device, right? So first one is right. Now, can we identify this supraglottic airway device? Can anyone put the name of this device? Anyone can put the name of this device in the chat box? I'm waiting for the name. I'm waiting for the name of this device in the chat box. Yep. LMA. No. Zafia. It's not LMA Pro Seal. It's not LMA Pro Seal. You can see we are trying to put a tube through it. This is intubating LMA. Yes, wonderful Anmol. It is intubating LMA, ILMA, fast track LMA. Yep, this device is intubating LMA. Right, this is intubating LMA. Right, intubating LMA. No, this is not classic LMA. Classic LMA cannot be used for intubation. We are putting a tube through it. Right? So this is ILMA or intubating LMA or The other name is fast track LMA, because this creates a track for the endotracheal tube. So intubating LMA or fast track LMA. So what was this device? Why was this device designed? This was designed when the intubation was difficult. We used to put this. We have already discussed it is all supraglottic devices are easy to insert, fast to insert. So I'm not able to intubate. I put this device, and I'm able to ventilate with this device. And after ventilation, once the patient saturation is 100%, I remove the circuit and a connection from the tube of this intubating element, put an endotracheal tube through it, and this endotracheal tube, the shape of device is such that the endotracheal tube will go into the glottic opening. So it is an aid in intubation. This is also correct. The cuff of the device is inflatable. Well, if you see a pilot balloon system, it has to be inflatable, right? So yes, this is also correct. So what is incorrect? There's a gastric drain present in the device, and this is incorrect, right? Now you can see there is no gastric drain visibly. Also you can see there's only one tube in this device. There's only one tube in this device. There's only one tube in this device. Okay. Now, traditionally, this device has not been given any generation. We all know that supraglottic airway device comes under first generation, and the second generation, right? First and the second generation, right? Now this first and second generation, how do we distinguish? So how do we distinguish between the first and the second generation, right? First generation and the second generation of supraglottic airway device. Now for first generation, we have one tube, and this tube is only used for, this is the airway tube, and this has only one work, ventilation, right? Then it has only one cuff for the seal, and then it has only one opening, right? So it has only everything one, first, one. Now second generation, there are two tubes, airway and the gastric drain, right? Airway tube, the gastric drain. It has two cuffs and it has two opening. The major demerit because of one cuff is poor seal over the glottic opening. So cannot prevent aspiration. So this device cannot prevent aspiration. Two cuffs. So comparable to ET tube in preventing aspiration. Comparable to ET tube in preventing aspiration. Got my point, everyone? Okay. Now, guys, very important. This you can see the intubating element doesn't have two tube. So traditionally, it is not in any generation, right? But if you have to give a generation, you cannot give it first generation, because it is doing one work extra. Apart from ventilation, it is also an aid in intubation. So if at all we want to give it a generation, though it is not traditionally put in any generation, we have to put it in the second generation. But again, I'm saying, if a question is like this, that which is second generation, and in the option is second generation, in the option is classical LMA, which is first generation, ProSeal LMA, and your intubating LMA. So what will you choose? You will choose the ProSeal LMA, because ProSeal LMA is clear-cut second generation. It has two tube, it has two curves, two opening, right? Intubating LMA traditionally has not been given any generation. Understood, everyone? So remember, it has not been traditionally given any generation. So this is intubating LMA. I hope everyone has understood this question as well. So coming on the 7th question. Okay. Again, this is favorite question of your exam. This has been asked so many times in your exam and in other exams as well. And then also it is getting repeated, right, everyone? So there is an increased resistance to breathing through endotracheal tube, predominantly due to. Now guys, when we intubate, there are two important. Okay. Now, my best wishes, Abingol. If you cleared FMG exam, definitely join us again for the PG entrance exam. The questions are mostly same. Keep your notes which you have used for FMG exam, even for the PG entrance exam. And I know you will clear with the flying colors. Okay. So, guys, the what are the two important changes which happens on intubation, right? So, whenever we put a ET tube, the patient now breathes through endotracheal tube, right? Now, please see on the screen. This is your trachea and this is your right and left bronchus. Now, normally we breathe through this. Now we breathe through this. Now, this is your trachea, and now what I have done, I have put a ET tube. Now, this is cuff, which is creating a seal. So now you are breathing through this endotracheal tube. So if I take a cross section of the trachea, this is the cross section of the trachea. And if I take cross section of trachea with ET tube, then guys, this is the cross section. So previously my ventilating lumen was this, and now my ventilating lumen is this. Now resistance is inversely proportional to the radius power of 4. So as the diameter decreases, resistance increases. So always whenever person is breathing through ET tube, always breathing through ET tube, you know, the work of breathing increases, right? Work of breathing increases because of the increased resistance. Okay. That's why whenever nowadays the ventilator try to dissipate this work of breathing by giving some more support when the person is intubated. Now guys, please see the question again carefully. Diameter of the tube, this is FMG or this is PG entrance, the NEET question, and I have to choose only one option. We cannot choose more than one option. Then I'll go for the answer diameter of the tube. But if it would have been the ionized set question and multiple option I could have chosen, multiple option, then I would have chosen all of them, because all these contribute in increasing the resistance. The diameter maximally, right? Length is also directly proportional to the resistance. Longer the tube, more is the resistance. Material also contribute. Curvature, if the tube is very much curved, then also this also contribute. So guys, if it was multiple option I would have gone for all four, but I have to choose single one best answer. Then I have to choose diameter of the tube. Got my point, everyone? Right, diameter of the tube. Got it, everyone? Understood this? Ashutosh, I don't understand your question. Why D? Why D? Whenever there is a curvature, the resistance through the curved part increases. That's why so many connectors which we put during ventilating a patient, we try to minimize it, because as many connector as we have put, more would be the resistance, right? So understood this? So answer is diameter of the tube. Diameter of the tube. Okay. Okay. Now here I want to tell you one more thing. I want to just talk about three important tube, their name and where we use it. First tube I want to talk about is flexometallic. Flexometallic or reinforced tube. Reinforced tube, or we call it armored tube. Armored tube. Now, flexometallic or reinforced or armored tube. This tube, it has a metallic wire reinforced on its inner diameter. So this has made it kink resistant. Yes, it's a metallic ring, right? Kink resistant. So this is tube of choice, flexometallic tube, tube of choice for neurosurgery, for head and neck surgery, any surgery where the airway area is shared by the surgeon, right? For dental surgery, for all these surgery. Even when we put the patient in prone position for spine surgery, we try to put this tube, okay? Then the second tube which I want to discuss is double lumen tube. Double lumen tube. Now double lumen tube, it has two lumen, one tracheal, one bronchial lumen, right? This is used for one lung ventilation, and this is the tube of choice for thoracic and cardiac surgery. This is you tube of choice for thoracic and cardiac surgery, right? Thoracic and cardiac surgery. And third tube I want to discuss is uncuffed tube. Uncuffed tube. I want to discuss is uncuffed tube. Now, uncuffed tube, unlike this tube and unlike the tube which has cuff, uncuffed tube doesn't have a cuff. So this is used in less than 5 to 7 years. Why? Because the narrowest part of, pediatric airway is cricoid, now subglottic area. Subglottis or cricoid is very prone to trauma and edema can happen. So to minimize the subglottic or cricoid edema, we use uncuffed tube. Uncuffed tube. Got my point? So uncuffed tube doesn't have a cuff. So these three important tube, which is what is the narrowest part of adult airway? Has been asked in last FMG exam. Glottic opening. Now this is the glottic opening, this is the trachea, this is right and left bronchus. This is the narrowest in adult, right? And in pediatric, subglottis, right? Subglottis in pediatric, right? So in pediatric, it is subglottis. In adult, it is glottic opening, right? Understood? Okay. Now coming on the 8th question. So guys, again, from a very important topic of your exam. So it's an image-based question, and I've just given an image and asked which grade would the following patient come in Malampati grading. So can you tell me which grade this patient comes in Malampati grading? Well, this is which grade of Malampati grading? Yep, I'm waiting. Okay. Very nice. Wonderful. Most of you are giving me the right answer. So answer is grade 4. Answer is grade 4. Okay, see on the screen. What is this Malampati grading? It's a pre-anesthetic evaluation to predict difficulty in intubation. Yes, everyone is correct. I'm so happy. You all are so well prepared. So Malampati grading is pre-anesthetic evaluation to predict difficulty in intubation. To predict difficulty in intubation. To predict difficulty in intubation, right? Difficulty in intubation, right everyone? Okay, so we have 4 grades. We have grade 1, grade 2, grade 3 and grade 4. Okay, if you see grade 1, in grade you just have to concentrate for recognizing the Malampati grade. You just have to concentrate on the soft palate, hard palate and uvula, right? So guys, if this is the uvula, right, and if there is gap between tongue and uvula, if there is a gap between tongue and uvula, then it is grade 1, right? Now if this is the uvula and the tongue is touching the tip of the uvula, then it is grade 2, right? And if it is, let's say this is uvula and tongue is overlapping the maximum part of the uvula, only the base of the uvula is seen, then this is grade 3. And if this is uvula and tongue is entirely covering it, only the hard palate above it is visible, then it is grade 4. So you just have to concentrate on uvula and tongue. Got it? Only yes. No, very important. You have to know the right words as well. Now this is uvula, this is tip, and this is the base from where it is hanging. So in grade 3, only the base is visible. So someone wrote Hari Venkatesh. Hari Venkatesh wrote in grade 3 only the tip of uvula is seen. No, tip of uvula is covered, base of uvula is seen. So here only the base of uvula is seen. Base of uvula, right? Here the entire uvula is seen, but tip is touching the tongue. Okay, and Grade 1, there's gap between tip of uvula and tongue. And here only hard palate, only hard palate. Hard palate. Okay, everyone? Okay, so I hope it is crystal clear that Malampati grading is pre-anesthetic evaluation to predict difficulty in intubation. So there is one more grading system which has been asked when Malampati grading has been asked. I just want to sensitize you. I haven't seen a question, individual question on that. So, but if they form the question from the options, then you have to be aware of Conmack Lehane grading system. Conmack Lehane grading system. Don't go for grade 0. Grade 0 is not established. It is just some people have rotated it on the online platforms. It is not something which is substantiated. So you only go for grade 1, 2, 3, 4. Got it? Okay, Conmark Lehane grading system. Conmark Lehane grading system. Now this is also a grading system to predict difficulty in intubation. This is also predicting difficulty. This is also predicting difficulty in intubation. But this is pre-anesthetic evaluation and this is not pre-anesthetic evaluation. This is not done during pre-anesthetic evaluation. Pre-anesthetic evaluation, not done during pre-anesthetic evaluation. Right. Conmark Lehane grading is laryngoscopic view of glottic opening. This is right. This is laryngoscopic, right, view of glottic opening. Right, laryngoscopic. Thank you, Sahu. Thank you, Sahu Kajal. Sahu Kajal. Okay, laryngoscopic. This is laryngoscopic view of glottic opening, right? Laryngoscopic view of glottic opening. Okay, everyone? Okay, everyone. If I'm able to see the entire glottic opening, this is CL grade 1. If I'm able to see only the posterior part of the glottic opening, only this much, then this is CL grade 2. And if only epiglottis, then this is CL grade 3. And only the hard palate, then this is CL grade 4. In 3 and 4, like Malampati grading, the intubation can be difficult. So it can have difficult intubation. Difficult intubation. And these 3, no difficulty anticipated. As in the Malampati grade 1 and 2, no difficulty. 3 and 4, difficult intubation. 3 and 4, difficult intubation. So crystal clear, everyone? So should I move to the next question? Question number 9. Okay, there should be an arrow on this. Okay. The image of the given device is important because, so they're asking with this image that what is this important for? Everyone, whether this tube or the tracheostomy tube, this is the endotracheal tube. This is the endotracheal tube. This is endotracheal tube, isn't it? This is endotracheal tube. Okay. Now, endotracheal tube is put from trachea. This we put from trachea, right? Okay. Now, this is trachea. And if I'm making a hole in trachea and then putting a tube, this is tracheostomy tube. Tracheostomy tube. Now, the tracheostomy tube also, most of the parts are similar. It also has the similar things. Just, it also has a cuff, everything like that, like the endotracheal tube. It just has a smaller size. So I told you previously that resistance is directly proportional to length. So compared to the ET tube, the resistance of ventilating through tracheostomy tube will be less. But this is also used for ventilation. If I have put a patient for a long-term ventilation, then we put this tracheostomy tube, right? For long-term ventilation, right, everyone? Now, whether they give a tracheostomy tube or put a arrow on the cuff, or ET tube, put an arrow on the cuff, they have the same purpose. They are the device which has been added to protect the lung from aspiration. So protect from aspiration, prevent tube from getting, no, even if you inflate the cuff and pull it, it will come out. Creates a seal for effective ventilation. So both A and C are correct. If I have to choose one, I have given this question again purposefully. If I have to choose one only, then I would choose protect against aspiration. Got my point, everyone? Okay, so remember, in this question, The answer would be A and C, but if I have to choose one, I would choose protects against aspiration. What my point, everyone? Okay, everyone. Now here I want to tell you a few things, that endotracheal tube and tracheostomy tube. Yes, tracheostomy. I'm trying to eliminate all your doubts because these are the questions asked. And anesthesia is one of the easiest subject in which you can score 100%. My most of the student, they score 100%. I want all of you to score 100%, right? And that helps in improving your marks both for the PG entrance as for the FMG clearance exam. And marks matter, as you all know. You will be eligible for INI-CET, and always dream for the top. You are the best. You have to dream for the top. Got my point? So tracheostomy too. Tracheostomy too. Okay. Now both are used for ventilation. So if I'm using them for mechanical ventilation. Now both should be cuffed. TT tube should also be cuffed. The tracheostomy tube also should be cuffed. So for mechanical ventilation, we should always use cuffed tube. Okay. What is the advantage of tracheostomy tube over ET tube? What are the advantage of tracheostomy tube over ET tube? The advantage is decreases decreases resistance to breathing. Number two, better pulmonary toileting. Better pulmonary toileting. It give us a better pulmonary toileting, right? So it give us a better pulmonary toileting, right? So better pulmonary cleaning, the tracheostomy tube. So we are using it for long-term ventilation, more useful for long-term ventilation, right? For short-term, we use ET tube, but if I have to keep a patient on mechanical ventilator for a long term, we use a tracheostomy tube. Understood? We use a tracheostomy tube. So this is something I wanted to add extra. Now coming on the 10th question, which of the following device can give highest concentration of oxygen? So oxygen delivering device, very frequently asked. 2 years back question paper. If you pick up the 2 years back paper, very frequently asked. From last 2 years, 4 exams, I haven't seen a question on it. But what I am seeing, the questions are being repeated from the last, let's say, before the 2 year papers. So somehow I'm suspecting that oxygen delivering devices again will be asked in this exam. So have a crystal clear view on oxygen delivering device. On oxygen delivering device. So what is the answer? Which of the following give highest concentration of oxygen? Oh my God, oh my God, oh my God, you are writing wrong answer. No, 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 no. Please read it again. Please read it again. Please read it again. Guys, please read it again. Think, think, think. The question is, which can give highest concentration of oxygen? Yep, I got a right answer. Sheila Sahani gave me the right answer. The answer is A, the rebreathing mask, or even if it is written non-rebreathing mask. NRM, NRBM, or NRM, non-rebreathing mask or rebreathing mask, whatever, right? Now please understand. 4 devices, oxygen delivering devices, you have to be crystal clear with. Oxygen delivering device. Oxygen delivering device. Delivering devices. 4 devices I want you to be crystal clear with. Number 1, nasal cannula. Number 2, face mask, normal face mask. Number 3, the rebreathing mask or non-rebreathing mask, anything written. Rebreathing mask or non-rebreathing mask. Non-rebreathing mask. And 4th one, Venturi mask. Venturi mask. Okay, everyone? These 4 devices. Now let us see their oxygen flow, their FiO2. Nasal cannula, we start with 1 liter and we can go up to 6 liter per minute oxygen per minute, right? Now every 1 liter, 4% above room air it supplies. So it can give from 25 to 45% oxygen concentration, 25 to 45%. Face mask, 5 to 6 liter we start and we go up to 10 liter per minute. So it can give us 33 to 60% oxygen concentration, right? Rebreathing mask, we start from 10 liter to 15, we can go for 10 to 12 liter per minute. This is for rebreathing mask, and for non-rebreathing mask, 10 liter to 15 liter per minute. Now, both comes under the category of face mask with a reservoir bag, right? Now, in rebreathing mask, it is said it can give oxygen concentration up to, let's say, 50 to 70%. And non-rebreathing, it can give from 70 to 90%. 70 to 90%. So, guys, they are giving a very high concentration of oxygen, right? They can give a very high concentration of oxygen. Venturi mask. Venturi mask, the flow we can start with 2 liter and go up to 15 liter per minute, and it can give from 25 to 60%, right? So maximum concentration of oxygen which Venturi mask can give is 60% only. Though compared to other three devices, Venturi mask is categorized under a different group. It is high flow fixed FiO2 delivering device. Venturi mask is high flow fixed FiO2 delivering device, fixed oxygen concentration delivering device, fixed oxygen concentration delivering device, right? So high flow fixed oxygen concentration delivering device. And these three comes under low flow variable FiO2, variable oxygen concentration delivering device, right? Here, the oxygen concentration will be fixed independent of the patient's breathing pattern. Here, oxygen concentration can vary. But here, what is the question? The highest oxygen concentration it can deliver. So if this is the question, the answer has to be the rebreathing mask or non-rebreathing mask, which both can give oxygen concentration more than Venturi mask. Though Venturi mask is a fixed oxygen delivering device, but the maximum FiO2 is less than what the non-rebreathing mask can give. Got it? So answer has to be the rebreathing mask. Understood? Got it? Everyone has understood, I presume. Yes? Everyone has understood, I presume. Okay? If not, put in the chat box. I'll come back. Okay? So 11th question. Again, based on what we have discussed, right? Which of the following device will deliver FiO2 between 0.25 to 0.5? I mean, arbitrarily FiO2 has been mentioned. Independent, but very important thing to notice is independent of patient's breathing pattern. Independent of patient's breathing pattern. This is something, the catch point in it. So independent of patient breathing pattern, so it has to be the high flow fixed FiO2 delivering device. It cannot be low flow variable FiO2 delivering device. So this is the variable FiO2 delivering device. This is a variable FiO2 delivering device. This is a fixed FiO2 delivering device. So this will be the answer. This is again the variable FiO2 delivering device. So answer is Venturi mask. This is the answer. Got it? Got it? So very quickly, we have two kind of devices. That is low flow variable FiO2 delivering device. Low flow variable FiO2 delivering device. In this, we have three devices. The normal nasal cannula, simple face mask, and face mask with reservoir bag, face mask with reservoir bag. Okay. Now, in this face mask with reservoir bag, we have rebreathing and non-rebreathing. Rebreathing and non-rebreathing. So all this comes under low flow variable FiO2 delivering device. Now, high flow fixed FiO2. High flow fixed FiO2. Fixed FiO2. High flow fixed FiO2 delivering device. We have what? We have Venturi mask, The prototype device, we have high flow nasal cannula. High flow nasal cannula, or HFNC, high flow nasal cannula, right? All this comes under the fixed FI rule. Even your ambu bag, ambu bag, hi DV Reddy, Devi Reddy, sorry, hi, hi Devi Reddy, ambu bag, all comes under high flow fixed FiO2 delivering device. Okay, now this ambu bag I want to contribute here. This can also be used for not only oxygenation, this can also be used for the ventilation, mechanical ventilation. So this can also be used for mechanical ventilation. So I always say ambu bag is your handheld ventilator, right? And ambu bag can give oxygen concentration from 21%, that is room air, to 100% if we have a source of oxygen attached to it. Okay, high flow fixed FiO2 delivering device. Got my point? Understood this? Okay. Okay, next question. Which statement is false about cardiopulmonary resuscitation? Now, very important question. Always one question from this topic is there. And recently, the question has been more on the choking in some of the recent exams. So I have formed this question on choking, right? So I want the answer. Let's see the options. Check chest compression should be done in 5 months old child unresponsive after choking. False statement we have to find. Hemlick's maneuver should be done in 9-month old child unresponsive after choking. First maneuver in an adult after choking is Hemlick's. Hemlick is only done above 1 year of age. So which is the false statement? Which is the false statement? Okay, okay, I'm waiting for the answer. Okay, so guys, let's talk about choking. Choking means anything which has gone into your airway and has completely obstructed, right? Anything has gone into the airway and has completely obstructed. So air passage will stop. The air passage will stop. Air passage will stop. What is the universal sign of choking? If they give the image, sound is also not coming. So air will stop, air will stop, and no voice. No voice. Right, this is choking. Now, how do we manage choking? How to manage choking? How to manage choking? Right? Number one, patient has been divided into two categories: less than 1 year and more than 1 year. Right? In less than 1 year, if the person is choking plus is responsive, sorry, I wrote the wrong spelling. Choking plus is responsive, still responsive, then less than 1 year, we do the back slap and chest thrust. We do back slap plus chest thrust. 5 back slaps and then we reverse and do chest thrust. So back slap and chest thrust. And for more than 1 year, all we do Hemlick's. Hemlick's. For more than 1 year, we do Hemlick's. And if the person is choked plus unresponsive, unresponsive. So for all this unresponsive, we do CPR, we do chest compression. So we do chest compression, we do chest compression. So remember, the rule is for any person who has become unresponsive, right, everyone, we have to do the basic life CPR. We have to do CPR. So here, when the choke person becomes unresponsive, we do chest compression. We do chest compression. So guys, chest compression should be done in 5-month-old child responsive after choking. This is correct. Hemlick's maneuver should be done 9-month-old child unresponsive after choking. So unresponsive, what we have to do? We have to do CPCR. That is chest compression. So this is wrong. First maneuver in adult after choking is Hemlick's. Yes, till they are responsive. Hemlick's is only done above 1 year. This is also correct. So this is the wrong, false statement. This is the false statement. Okay, everyone has understood, I presume? Cool, everyone has understood? I expect a question on choking. I expect a question on choking. So this slide is important for you. A question on choking. Okay? Okay. Next. The correct sequence of resuscitation. Guys, BLS is something, basic life support is something which is very commonly asked. I mean, most commonly asked. Basic life support is something which is most commonly asked. Okay. First, there are three questions asked on basic life support. One, they ask about the resuscitation triangle. They ask about the sequence of BLS, and they ask about high quality chest compression. High quality chest compression. High, what are the features of high quality chest compression? So I have made a question on sequence. So what should be the sequence of BLS? So sequence of BLS. Now sequence of BLS, first thing should be scene safety. If it is there, we have to first go mark scene safety, followed by followed by early assessment, early assessment, right, and call for help, call for help, call for help. Then check pulse and breathing. After calling for help, you check pulse and breathing. Then start high quality chest compression. You start high quality chest compression, right? Then you defibrillate, defibrillate as soon as possible, and post resuscitation care. So this is the sequence of BLS. So let's see: early assessment, CPR, defibrillation, followed by ACLS. Yes. So this seems a side sequence. CPR. Why would we do CPR before assessment? No, 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 guys. CPR, defibrillation. No, again this is wrong. Early assessment. Again this is wrong. So answer is A. So this sequence is very important sequence. So next thing which I told you, you have to know about the resuscitation triangle. So what is the three features of the resuscitation triangle? Who will put it? Who will tell me in the chat box? The three important cardinal features of resuscitation. The cardinal feature of resuscitation. Yep. What are the cardinal feature of resuscitation? Yes, guys, compression, ventilation, and defibrillation. Yeah, compression, ventilation, and defibrillation. So remember, these are the three cardinal feature of BLS. Then we have to know about, no. J, it is not ABC, it is CAB, right, for cardiac arrest. ABC is for trauma. This is for trauma and responsive person. And this is CAB is for cardiac arrest. Cardiac arrest. Got it? Then they ask about high quality chest compression. Yes. They ask about high quality chest compression. So remember, high quality chest compression, what are the features of high quality chest compression? The features are push hard, push hard. How hard? 5 centimeter at least, right, in adult. Push fast. How fast? 100 to 120 compression per minute. Then allow complete recoil. Allow complete recoil. So we have to allow complete recoil. Then just minimum interruption. Minimum interruption. Now, one more thing I want to add: minimum interruption in chest compression. Guys, uh, the chest compression fraction we should aim. Chest compression fraction means how much time you are doing chest compression in total resuscitation time. Should be more than 80%, the chest compression fraction. And just adequate ventilation. Just adequate ventilation. So these are the 5 feature of high quality chest compression. Now ratio is something else. These are the features of high quality chest compression. Ratio, you all remember that 30:2 is for adult, any number of compressor ventilator, and this is for adult always. This is the fixed ratio for adult. And for pediatric, it is 30:2 if there is one person, and 15:2. 15:2 if there are more than one person. Okay? So you have to remember. Now here sequence is important, and there is one more thing which they are asking lately is this chain of survival. Chain of survival. They are asking question on chain of survival. So guys, there are 6 links in the chain of survival of cardiac arrest. 6 links, right? In cardiac arrest chain of survival, right? So out of hospital and in hospital. There are 2 chains, out of hospital, chain, and in hospital. Everyone, see what are the features of the chain. Now, out of hospital, the first thing which you do is whenever you come across a person in cardiac arrest, you call for help. So we call for help. So this is the first chain. After first link of the chain. Now the second is you start high quality chest compression. So you start chest compression. This is the second. Then the third link is you have to do a early defibrillation. So defibrillation, early defibrillation, right? And then you have to go for call for help, chest compression, defibrillation, then shift the patient to the hospital, right? Shift to hospital, then post resuscitation care, post resuscitation care, and the last link which has been recently added in 2024 is recovery. This is the 6th link which has been added, right? In hospital, we have first is to prevent the cardiac arrest. First one is prevention. Second one is call for help. Third one is chest compression. Fourth one is defibrillation. Fifth one is post resuscitation care, and sixth one is recovery. So we have 6th link. Scene safety, etc. That is the sequence of BLS. These are the 6 chains of chain of survival. These are 6 chains of chain of survival. You're getting my point. So in hospital, when a patient is admitted, first chain is try to prevent cardiac arrest from happening. But if it happens, it is same. You call for help because you cannot manage cardiac arrest alone for a long time. Then chest compression, start defibrillation, post resuscitation care, then recovery. 6th chain has been added in 2024. Date is also important. It was added in 2024. 6th chain is added in 2024. If they ask the date, last year it was added, the 6th chain, and it was asked in your exam also from last year. Okay, understood? So coming on the next question. Okay, compression ventilation ratio in 1-year-old child with multiple rescuers in cardiopulmonary resuscitation is 1-year-old. Okay, so what's the answer? Answer is, just now I discussed 15 is to 2. 15 is to 2. Everyone, I want to talk about the difference in the resuscitation of adult, pediatric, and infant. So adult, right? Pediatric and infant. Okay, everyone? Adult means puberty onwards. Pediatric, 1 year to puberty. And infant, less than 1 year, excluding newborn. So you have to know this, excluding newborn. In adult, the pulse which we feel for diagnosing cardiac arrest is always carotid. Pediatric, it is either carotid or femoral. Infant, it is always brachial pulse. So this is for pulse. Okay. Then the resuscitation ratio, the compression ventilation ratio, adult always 30 is to 2, pediatric and infant 30 is to 2 when one rescuer, and 15 is to 2 if more than one rescuer, right? Then adult compression depth at least 5 centimeter. Here pediatric about 5 centimeter, infant about 4 centimeter, right? Understood? Okay. Then remember that the resuscitation technique little bit differs in infant. In adult, it is we do it with both hand. So both hand, we do it with both hand, the chest compression. Pediatric, both or single hand, depending upon the build of the child. And infant, either two finger technique we go for, two finger technique, or thumb encircling technique. Thumb encircling technique. So these are the ways of doing the chest compression, thumb encircling technique in infant. Okay. So this is in BLS I'm talking about. I'm talking about only BLS. Okay, everyone. Now 3:1. What is this 3:1? This is for newborn. This is for newborn, which has been excluded in my infant. So never get confused. Newborn, the compression ventilation ratio is 3:1. 15:2 for pediatric and infant if more than one rescuer. 30:2 for pediatric and infant if there is one rescuer, and adult always. Got it? So answer is 15:2. Okay, next question. Okay, during evaluation of emergency patient, primary assessment, all of the following investigation is done except. So guys, what do I mean by this word primary assessment? Primary assessment. Now primary assessment is done for an undifferentiated, responsive or conscious emergency patient. So for undifferentiated, I don't know the problem, undifferentiated conscious emergency patient. So whenever we get a conscious emergency patient, we go for ABCD approach. A, B, C, D, E approach. ABCD approach. है ना? ABCD approach means your airway. We have to stabilize the airway. We have to stabilize the breathing of the patient. Circulation, disability, and we have to expose and see the problem. Okay, now this is done there in the emergency itself, and this is patient we are we have to assess, intervene and reassess. So we have to assess, then we have to intervene and secure these, and then we have to assess again. And during doing this, we don't move the patient. We don't move the patient. So whatever investigation we have to do, it should be bedside. So only bedside investigation. So only bedside investigation. So chest x-ray, can we do bedside? Yes, we can do it. Portable chest x-ray. CT scan, can you do bedside? No. So this is not done in primary assessment. Bedside ultrasound, yes. Blood investigation, yes. So answer is your CT scan. Got it, everyone? Remember, CT scan, MRI, whatever you want to do, you do it in secondary assessment. So after primary assessment, in these patients, we go for secondary assessment. Secondary assessment is assessment to find the cause. Yes. E-fast is the part of primary assessment. Guys, remember. Yes, creative username. Okay. E-fast is part of primary assessment. Right? We try to immediately see that what is compromising the airway, breathing or circulation of the patient. Here we have to optimize these three systems, right? Yes, CT once the patient is stabilized. Okay, now coming on the 16th question. Which of the following is true about local anesthetic systemic toxicity of bupivacaine? So we have to find the true statement. Let's see all the statement. So the question is on local anesthetic systemic toxicity, right? 20% intralipid is the rescue therapy in local anesthetic systemic toxicity. Now, this seems the true statement. The risk of serious toxicity decreases in pregnancy. Actually, it increases in pregnancy. Pregnant ladies more sensitive to local anesthetic. Central nervous system toxicity is less common than serious. No. CNS toxicity more common happens at a lower dose compared to serious toxicity. This is also wrong. Systemic vascular resistance is unchanged. No, hypertension is one of the cardinal feature of your local anesthetic systemic toxicity. So answer is A. Now here, why I have chosen this question purposefully, just to train you for a certain type of question. There would be a certain type of question in which you may not be knowing about it everything, but there would be one point which has been asked repeatedly on that topic. In last, what has been repeatedly asked? The antidote, the 20% intralipid as the rescue therapy. So they will give one option which seems you must be knowing. You have to know that option. So you will go for that answer. You're getting my point, right? There is something called calculative guess for the exam question. The calculative guess means that you are ruling out the other option by knowing what one or two things are right for that particular question. So you can take calculative guesses, right? And as many you give the grand test and all, you learn how to take the calculative guesses, right? So yes, calculative guesses can be taken, right? Okay, so guys, local anesthetic systemic toxicity, or last, local anesthetic systemic toxicity. Two important systems are involved: CNS and CVS. CNS and CVS. In CNS, first the CNS excitation happens. This is more common. CNS toxicity more common, happens at lower dose, happens at lower dose. And the clinical feature is that patient becomes apprehensive. Then the circumoral numbness. This is the cardinal feature, circumoral numbness. This is the cardinal feature, the circumoral numbness. Then tinnitus, and seizure. These are the CNS toxicity features. CVS toxicity, hypotension, then your arrhythmia, and cardiac arrest. Right, everyone? Remember, how do we manage it? Management, very simple. Symptomatic plus antidote, 20% intralipid emulsion, right? This is the antidote. Yes, arrhythmia. Now, if patient is having arrhythmia, what will be the symptom? Arrhythmia. So how would we manage? We'll give amiodarone plus 20% intralipid emulsion. Patient is in cardiac arrest. How do we manage cardiac arrest? CPR plus 20% intralipid emulsion. Hypotension, I would give inotrope plus 20% intralipid emulsion. Seizure, I'll give midazolam plus 20% intralipid emulsion. So this plus 20% intralipid emulsion is antidote. Okay, understood. Next question. Okay. A 47 years old female with past medical history of type 2 diabetes mellitus, hyperlipidemia, presents with the symptom of dizziness and fatigue. So she's having dizziness and fatigue. So this could be because of low oxygen supply. On physical examination, her blood pressure is 90/66. So she is in hypotension. Respiratory rate is 18 per minute. Temperature is 98.6. An ECG done bedside and following rhythm is seen. Now this ECG, as you can see, it is showing bradycardia. So this is bradycardia, and patient is having symptomatic bradycardia. So guys, if someone is having symptomatic bradycardia, the answer is we have to give atropine. So let's see the option. Oxygen plus lidocaine. Well, lidocaine is used for arrhythmias, not for bradycardia. Oxygen plus atropine, this seems the right answer. Verapamil and morphine, no. Oxygen plus verapamil, these are antiarrhythmic drugs. So oxygen plus atropine. Guys, very important. I just want to tell you a few things about bradycardia and bradyarrhythmias. How do we manage? Any question on bradycardia or bradyarrhythmia? Now, bradycardia or bradyarrhythmia, the heart rate is less than 60 and This can be symptomatic, this can produce symptom also, and this can be asymptomatic, the bradycardia, but not producing any symptom. What could be the symptom? The symptom can be because of the low cardiac output, because cardiac output is equal to heart rate into stroke volume. So if heart rate is less, the cardiac output will be less. And two system screams loudly if they don't get the blood: brain and heart, brain and heart. So all the symptoms will be of brain and heart. So this patient was having dizziness, so brain is not getting adequate blood. This patient is having hypotension, heart is not able to pump the adequate blood. So symptomatic, what would be the symptoms? Symptoms would be the patient was having decreased consciousness, right? Patient will be having dizziness, patient would having acute heart failure, these kind of features. Patient will show the features of shock, symptomatic. If the bradyarrhythmia or bradycardia is symptomatic, the drug of choice is always atropine. Atropine, right? Atropine you have to give. Atropine, the dose is 1 milligram, right? Every 3 to 5 minutes. Every 3 to 5 minutes. Maximum is, maximum dose is 3 milligram. 3 milligram. So remember this dose. Okay. If it is asymptomatic, we just have to monitor and do nothing. Monitor and do nothing. We just attach oxygen, monitor and do nothing. So if this patient would have, the blood pressure would have been, let's say 120 by 60, and no, and then I would have just attached oxygen and waited. If patient would have been improved, I would not have given atropine, but she was having even the hypotension, so I would give atropine. Yes, max is 3 milligram. Okay, got it. So remember this about bradyarrhythmias or bradycardia. Okay, next question. In a patient with VF, ventricular fibrillation, refractory to repeated attempts at defibrillation. So VF is a non-compatible rhythm of heart. In VF, what kind of ECG pattern we get? We get a, I always say to my students, ki give pen in a hand of 1-year-old child and ask him to draw anything on the copy, and whatever he draws is VF. So it's ara, tirsha, ulta, seedha lines. But there are some lines. It is not asystole. It is not straight line. So this is VF. So when a VF or pulseless ventricular tachycardia, the management is same. In this, whenever we see a patient in VF, we are doing CPR because they are incompatible with life. Immediately we have to give defibrillation. Shock is must. Defibrillation. After defibrillation, we do CPR for 2 minutes. And during this CPR, when we have a 2 minutes time to do, we are doing CPR, one person can put IV line or interosseous. If IV is not possible, interosseous line. Right? Again, I see the rhythm is same. Again, after 2 minutes, I will do defibrillation. And again, I will start with CPR for next 2 minutes. And now I will start giving medication, adrenaline. Always, the first drug is adrenaline. Adrenaline, the dose is 1 milligram, 1 in 10,000 concentration. This is for adult. And for pediatric, it is 0.1 milligram per kg, 1 in 10,000. This is for pediatric ADR. And we repeat ADR every 3 to 5 minutes. Every 3 to 5 minutes, we repeat it. Now, after several attempts of defibrillation and ADR, patient is not reviving, then the next drug which we can give is amiodarone. Amiodarone, only 2 doses are given in cardiac arrest. First dose is 300 milligram, right? Yes. And the second dose, Prapati, you are writing 1 milligram, 1,000 concentration. No. Cardiac arrest IV. We give IV, it's 1 in 10,000. So change it. First dose 300 milligram and second dose is 150 milligram. Right? So we give amiodarone. What does amiodarone do? It sensitizes the heart to the shock. It makes the heart sensitive to shock. So there's a chance if this defibrillation is not changing the rhythm into cardiac rhythm, that is the sinus rhythm, after giving amiodarone, it will get changed. If amiodarone is not there, then we go for lidocaine. Lidocaine. So if amiodarone is not there, then we go for lidocaine. But not procainamide, not propanol, not quinidine. These are used in managing symptomatic tachyarrhythmias, not in cardiac arrest. Yes. So if you ask me for VF and VT, the two shockable rhythm, and asystole and pulseless electrical activity, these are non-shockable rhythm. What are the drugs which we use? For VF and VT, adrenaline and then amiodarone, and if amiodarone is not there, lidocaine. Lidocaine. For asystole and pulseless electrical activity, there is only one drug, adrenaline, nothing else. And guys, in VF and VT, one extra thing which we can do apart from let's say CPR and the drug is defibrillation. Defibrillation, we give shock. Here, no defibrillation. So guys, remember, for VF and VT, these are the intervention apart from CPCR. CPCR we do in both. And asystole and PEA, there's only one thing which we can do apart from CPCR, that is adrenaline, 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 and adrenaline, and adrenaline, and adrenaline. So even I have given 10 doses of adrenaline every 3 to 5 minutes. There is no other drug which I can give. ADR, 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 ADR. For VF and VT, ADR, defibrillation, patient is not responding, amiodarone or lidocaine, right? There is no upper limit of ADR, there is no upper limit of defibrillation. We can do as many times as we want. Understood? Okay, next. Which of the following inhalational anesthetic agents' unique physical properties requires a special vaporizer for it? So guys, vaporizers are the device which is used for, these vaporizers are device used for delivering inhalational agent. Delivering inhalational agent. Now, inhalational agents, these agents, they are liquid at room temperature. They are liquid at room temperature. So to construct a vaporizer, we have to know about their boiling point, and we have to know about their vapor pressure. And for your desflurane, both are different. Both are different compared to other agents. So answer has to be desflurane. D is desflurane, D is different. Desflurane is different. So needs a special vaporizer. And one example of special vaporizer is Tech 6 vaporizer. Tech 6 vaporizer. Desflurane is special. Okay guys, these agents, these three can be given by a similar vaporizer, but not by the same vaporizer. Vaporizers are agent specific. These are different chemicals. Though they have a similar physical properties, we cannot use a same vaporizer for all. They are similar vaporizers, but not same. So we maintain a color coding. Halothane has a red color code. Isoflurane has a purple color code, and sevoflurane has a yellow color code. Desflurane is the royal one. It has a blue color code. Right, everyone? So color coding is important. Now, two important questions I want to revise here. One is about MAC, minimum alveolar concentration, and other is about blood gas partition coefficient. Blood gas partition coefficient. Blood gas partition coefficient. MAC is telling us about potency. MAC tell us about potency. MAC tell us about potency. Now, potency is inversely proportional to MAC, right? So the lowest MAC is of methoxy, which makes it most potent, followed by halothane, followed by isoflurane, followed by sevoflurane, followed by desflurane, followed by xenon, followed by nitrous oxide. Nitrous oxide has highest MAC. Highest MAC, the MAC is 104. So this is least potent. Highest MAC, and this is least potent. Got my point? So most potent to least potent, right? And blood gas solubility tell us about speed. Speed. speed of induction, right? So high blood gas solubility, slow speed. So high blood gas solubility, slow speed, right everyone? So let's see the speed from fast to slow. So lowest blood gas solubility we have of xenon. Xenon has lowest blood gas solubility. Then nitrous oxide blood gas solubility is equal to your desflurane, equal to desflurane, right? Then we have SIVO, then we have iso, and then we have halothane, right? So fast to slow, fast to slow. So these two sequence you have to remember, fast to slow. Okay. Right? Fast to slow, fast to slow. Come on Yashira, मिक्सचर की आवाज नहीं आएगी, मेरा रूम किचन से बहुत दूर है, यहाँ कोई आवाज नहीं आएगी. Okay, understood everyone? Got it? Got it? This is important. Both are important. Both are important. ठीक है? Okay, next question. Which of the following is not property of ketamine for its clinical use during anesthesia? So some unique property of ketamine which help us in using ketamine during anesthesia. So we just have to be aware of the properties of ketamine. Okay. So guys, ketamine we can use along with other anesthetic agents also. And when we are using two anesthetic agents, whether we are using ketamine with propofol, we use like combination, we use ketofol or ketodex, something like this we use, है ना? We use the combination. What happens that one anesthetic agent decreases the dose of other anesthetic agent. So this decreases the requirement of opioids contributing. Ketamine is good analgesic. It's a good analgesic. So it contributes in analgesia. So it also decreases opioid requirement. So it decreases the opioid requirement for analgesia. It has opioid sparing effect. It has opioid sparing effect. It potentiates opioid as well. It potentiates opioid for pain relief. So it's very good analgesic, contributing in every way for pain. So decreases the requirement of opioid. This is correct. Maintains hemodynamics. Now, why do we combine ketamine with propofol, etc.? Because propofol would decrease BP, ketamine would increase BP. So it increases blood pressure, it maintains hemodynamics. Very good. Then ketamine acts on NMDA receptor. Yes, yes. All the other acts on GABA. So most of them acts on GABA, ketamine acts on NMDA receptor. Okay. Uh, okay, I'll come on that. Salma. No, salam. Okay, drop in blood pressure. Ketamine does not do drop in blood pressure. So this is incorrect, right? This is not the property of ketamine. Not the property of ketamine, drop in blood pressure. Okay, now guys, very important. Let us talk about where they are indicated. So thiopentone, propofol, etomidate, and ketamine. है ना? Now thiopentone for anesthesia nowadays has become obsolete. Never ever anesthetic agent of choice. Answer can be thiopentone. But thiopentone is drug of choice. Drug of choice. Drug of choice in number one. Narcoanalysis. Narcoanalysis has been asked. And neuroprotection. Neuroprotection. Narcoanalysis, neuroprotection. Propofol, it is one of the best anesthetic agent of choice in many conditions. I'll come there. But before that, etomidate. Etomidate has 2 star. One red star, it is cardio stable. And because of this cardio stable, it is anesthetic agent of choice in cardiac patient. Keto, and it has one black star also. It inhibits cortisol synthesis. Inhibits cortisol synthesis. So that's why we don't use it for other patients. Only for cardiac patient we have reserved it because it inhibits cortisol synthesis. Ketamine is anesthetic agent of choice in shock, anesthetic agent of choice in bronchial asthma, bronchial asthma, and cyanotic heart disease. Cyanotic heart disease. Cyanotic heart disease. So all this, it is anesthetic agent of choice. Cyanotic heart disease like tetralogy of Fowler, etc. This is the anesthetic agent of choice because it will increase the blood pressure and decrease the shunt fraction. Right. Anything else apart from shock, bronchial asthma, cyanotic heart disease, and cardiac patient, everything anesthetic agent of choice is propofol. So propofol is anesthetic agent of choice in daycare surgery, for neurosurgery, for thoracic surgery, for renal patient, for liver disease patient. You're getting my point? For malignant hyperthermia, for porphyria patient. I can go on writing, go on writing, go on writing. Propofol is agent of choice, right? There are few unconventional uses. Now, ketamine has two unconventional uses. Number one in pain management, and number two as an antidepressant. Antidepressant. We use it as antidepressant. It's a newer antidepressant. And propofol has one conventional rule use. It is anti-emetic. So these are few important things. This important table you have to keep in mind. One more thing about ketamine. Remember that ketamine, most common side effect of ketamine is emergence. Most common side effect is emergence emergence delirium. It causes hallucination after recovery, emergence delirium. And dissociative anesthesia is a special anesthesia produced by ketamine. It's different from emergence delirium. Emergence delirium happens in post-op. Dissociative anesthesia is a type of anesthesia, special type of anesthesia, right? So dissociative anesthesia is a special type of anesthesia, and emergence delirium is different. Got it? So keep these two things separate in your mind. Okay, should be crystal clear in these things. Okay. Okay, next question. Okay, which of the following statement is not true statement about IV anesthetic agent? So they have asked untrue statement about IV anesthetic agent. So let's find the untrue statement. Most intravenous anesthetic agent acts on GABA. Yes, this is correct. Except ketamine, which acts on NMDA. NMDA. Okay. Intermediate is cardiovascular stable. Yes. The rest all are cardio unstable. Intermediate is cardio stable. Thiopentone, propofol, and ketamine. Cardio unstable. Cardio unstable. Okay. Ketamine causes pain. Oh my God. We have written ketamine is a very good analgesic. It can cause anything, but it cannot cause pain. So ketamine does not cause pain. Right. So this is not true. Propofol gives pleasant recovery. Very pleasant recovery. It gives a beautiful pleasant recovery. It's a euphoric drug. Propofol is a euphoric drug. Okay. Okay, guys. Drugs causing pain on injection. Drugs causing pain on injection. Pain on injection. So guys, propofol, most common drug causing pain on injection. Then etomidate can also cause. Some preparation of etomidate can cause pain on injection. Then there is another drug, methoxytone. Methoxytone. Methoxytone can also cause pain on injection. So it's a barbiturate. Methoxytone is a barbiturate. It can also cause pain on injection. Diazepam can cause pain on injection. Diazepam. And one muscle relaxant can cause pain on injection, rocuronium. So remember rocuronium also. Rocuronium can also cause pain on injection. So these are the drugs which can cause pain on injection. Remember, pain on injection. These are the important drugs causing pain on injection. Understood? Okay. So remember this table. Okay. Okay. Okay, guys. Next question. A 77-year-old male presents to the emergency department with a small bowel obstruction requiring a emergency exploratory laparotomy. The patient is experiencing a significant nausea and vomiting. Uh, I would not do. It is, I wouldn't prescribe ketamine. It's a habit forming drug, and it's a drug of substance abuse. Why, guys? You should be in high without any drug, That Friend star, Matthew Perry, he died because of ketamine overdose. Never, never. Okay. So coming back on question. So patient is prepared for RSI, rapid sequence induction intubation. The which of the following allows patient to be able to safely give an RSI? So guys, for rapid sequence induction intubation, The most common muscle relaxant used is succinylcholine, right? So we use succinylcholine. Why we use succinylcholine? Because it is fastest, because of the fastest onset within 30 to 45 seconds. 30 to 45 seconds, fastest onset within 30 to 45 seconds, fastest onset within 30 to 45 seconds, right? We use it. But if succinylcholine we cannot use it, then we use rocuronium. So if any contraindication of succinylcholine is present in patient, then we use rocuronium. So what are the problems of succinylcholine where we cannot use succinylcholine? So patient having family history of muscle dystrophy. If I would give a patient succinylcholine, and if a patient has a family history of muscle dystrophy, this can cause exaggerated hyperkalemia. Succinylcholine causes hyperkalemia, and this can cause exaggerated hyperkalemia. This can cause exaggerated hyperkalemia, right? Okay. Patient having serum potassium more than 6. Well, if patient already have a high serum potassium, it will further increase the potassium. It can cause arrhythmias. So it can cause arrhythmia. I would not use it. History of burn injury 6 months back, we never use. In burn patient, there is exaggerated hyperkalemia. So there's a risk of exaggerated hyperkalemia. So in all these three patients, it is not safe to give succinylcholine. So we will not give succinylcholine, we will give rocuronium. We will use rocuronium. Got my point? Guys, what are the side effects of succinylcholine? Side effects of succinylcholine. The first side effect of succinylcholine is it is causing fasciculation. Fasciculation. It is causing fasciculation, right? The second side effect is post-operative myalgia. Post-operative myalgia. It can cause post-op myalgia. Number 3, fasciculation, post-op myalgia. Number 3, it can increase the pressures. Increase intraocular pressure, intragastric pressure, intracranial pressure. Then fourth, it can cause hypokalemia. It can cause hyperkalemia. Succinylcholine can cause hyperkalemia. It always increases potassium. And in some patient, it causes exaggerated hyperkalemia. Exaggerated hyperkalemia. So what are the patients in which it can cause exaggerated hyperkalemia? It can cause exaggerated hyperkalemia in muscle dystrophy patient, right, dystrophy patient. It can cause exaggerated hyperkalemia in paraplegic patient, muscle disuse patient, paraplegia. It can cause exaggerated hyperkalemia in muscle disuse, neuromuscular diseases, etc. Neuromuscular diseases. And it can cause exaggerated hyperkalemia in burn patient, and even in trauma patient we avoid because of the risk of already hyperkalemia present in them. So in these patients, succinylcholine is contraindicated. Okay, and succinylcholine can also cause bradycardia because it is mirror image of acetylcholine, so it can act on muscarinic receptor. And succinylcholine can trigger malignant hypothermia. It can trigger malignant hyperthermia. So it can trigger malignant hyperthermia. So succinylcholine can trigger malignant hyperthermia. Okay, so you have to remember these side effects of succinylcholine, important for exam. Okay, now coming on 23rd question. So a 24 years old female developed masseter muscle spasm. Okay, first point. Then she developed masseter muscle spasm after IV succinylcholine. EtCO2 progressively increases, heart rate increases, temperature rises. Management include all except. So guys, first though I have to make the diagnosis. What is the condition? So what is the condition? It is malignant hypothermia. Malignant hyperthermia. It is malignant hyperthermia, right? So this is malignant hyperthermia. Okay, everyone? Okay. Now, guys, how do we manage malignant hypothermia? In malignant hypothermia, management is three things. First, stop the triggering agent. Stop triggering agent. Then, number two, IV dantrolene. I start IV dantrolene, right? This is the antidote. And third, symptomatic management. Symptomatic management. We manage the symptom. So halothane is one of the triggering agent for malignant hypothermia. So we have to stop halothane. So this is a wrong statement. Hyperventilate with 100% oxygen? Yes. Patient is having EtCO2 increase. So we start hyperventilating to clear the CO2. So this is right. Patient is temperature is increasing. So we use the cooling maneuver. And acidosis we treat. Right? So what is wrong? Start halothane to decrease the heart rate. Cool? Understood? Okay, guys, malignant hypothermia is a very important topic. Malignant hypothermia is very important, right? Malignant hypothermia. So remember, in malignant hypothermia, patient will have a gene, MH gene we call it, malignant hypothermic gene. And if someone with this gene is given triggering drug. So what are the triggering drug? Three drugs are triggering drug. Number one, what is the triggering drug? Succinylcholine. We have written succinylcholine. This is the triggering drug. And number two, halothane, isoflurane, sevoflurane, desflurane. These are the triggering drug. And lignocaine is the triggering drug. So if patient is given this triggering drug, what happens? That the sarcoplasmic reticulum started huge calcium release. So increased calcium release inside inside muscle cells, muscle cell. So this has been also asked recently in exam. What happens in malignant hypothermia? Increased calcium release. This causes hypermetabolism. Hypermetabolism. So this hypermetabolism produces muscle spasm. This can cause increased CO2, increased blood pressure, increased heart rate, arrhythmia, and hyperthermia, and plus muscle breakdown. So acidosis plus hyperkalemia because of the muscle breakdown, etc., will start happening. Myoglobinuria, etc., and your renal failure. Patient can go into renal failure. So immediately I have to manage, I have to stop this hypermetabolism. What is causing this hypermetabolism? This calcium is causing. So first thing, we stop this triggering agent. So we stop the triggering agent. Triggering agent we have to completely wash off. And we have to do something to stop this calcium. This dantrolene stops the calcium release. And we treat the patient for all these symptoms because these symptoms can be life-threatening. So we do the symptomatic management. So this is how we manage malignant hypothermia. Now they can ask another type of question. Drugs safe in malignant hypothermia. Drugs safe in malignant hypothermia. So remember, your IV anesthetic agents are safe. Intravenous anesthetic agents are safe in malignant hypothermia. Number two, your IV agents are safe in malignant hypothermia. Number two is your, let's say, nitrous oxide, xenon is also safe. Nitrous oxide and xenon is also safe in malignant hypothermia. And number three, non-depolarizing, rocuronium, vecuronium, etc. are safe. Yes, we use TIVA for malignant hypothermia. You're absolutely right, Ashutosh. Right? Ashutosh. It is not Ashutosh, it is Ashutosh. Okay. It's a new name. Okay. So nitrous oxide and xenon is safe. And your, what I said? Non-depolarizing. Non-depolarizing neuromuscular blocking agent, that is ROC, VEC, etc. are safe. Okay, so this is all about malignant hyperthermia, right? Yep. Dr. Dorao. Okay, whenever I take your classes, especially the online classes, such a unique names I learn. I somehow, some of the names I write down in my copy to use it for future. Okay. Okay, which of the following is the last layer to be pierced when entering the lumbar cisternae? Lumbar cisternae. Lumbar cisternae. So what is lumbar cisternae? What is lumbar cisternae? Lumbar cisternae is dilated subarachnoid space. Dilated subarachnoid space. It is dilated subarachnoid space. So when you have to enter the subarachnoid space, the last layer which you have to pierce is subarachnoid matter. So this will be the answer. Subarachnoid. Oh my God. Why are you putting wrong answers? Lumbar cisternae is subarachnoid space. C would be the answer. Yup. Ligamentum flavum, last layer would be for epidural. This would be for epidural, right? Subarachnoid matter is for spinal anesthesia, and this lumbar cisternae is dilated subarachnoid space. So lumbar cisternae, right? Lumbar cisternae is dilated subarachnoid space. So C answer. Got it? So what are the layers which we pierce if the sequence? The first layer is skin, then subcutaneous fascia, then your let's say supraspinous ligament, and then interspinous ligament, and then ligamentum flavum, and then dura, and then arachnoid matter, right? When I enter arachnoid matter, pierce arachnoid matter, I enter subarachnoid space for spinal anesthesia. We see a return of CSF here. For epidural, we stop at this level because for epidural it is extradural. So for epidural, we stop at this level. So last layer for epidural is ligamentum flavum. For subarachnoid space and lumbar cisternae is arachnoid matter. Now there is a special type of epidural, that is caudal anesthesia. Now caudal anesthesia is epidural in the sacral part of the lumbar canal, and there the ligamentum flavum is modified into sacrococcygeal ligament. So for caudal, agar specifically they ask, the answer would be sacrococcygeal ligament, the last layer, sacrococcygeal ligament. This is a modified ligamentum flavum. Okay, coming on the last question. Okay, I took a difficult question for the last question. A 50 kg patient with acute lung injury was put on mechanical ventilation in assist control volume mode with following setting: tidal volume 420, respiratory rate 17, IE ratio 1:2, PEEP 10, and FiO 2.9. The patient was hemodynamically stable. After setting, 20 minutes after that, we did ABG. This was the result of ABG. Now, what change in the setting should be done? So whenever we put the patient on ventilator, after 20-30 minutes we do a ABG and see the values, and then we can change the settings of the ventilator as it is required. Okay, so how do we do the setting of ventilator? Now, setting of ventilator. So why do you put a patient on ventilator? You put a patient on ventilator to improve the oxygenation or ventilation. Right? So you put a patient for this only. So what is the initial setting of the ventilator? The first thing, we have to set the tidal volume. So tidal volume, normally we set 6 to 8 ml per kg body weight. Then the second setting is respiratory rate. The respiratory rate, normally we put 12 to 25 breath. Whatever was the respiratory rate of the patient before intubation, we kind of keep it near. Then IE ratio, the inspiratory-expiratory ratio, normally keep 1:2. We can increase it depending upon the time required we want to give for inspiration and expiration. Like in COPD patient, we increase it to 1:4, right? But normally 1:2. Then we keep something called PEEP, positive end expiratory pressure. This keeps the alveoli expanded. To keep the alveoli expanded and improve the oxygenation, we start with 5 centimeter of water. We can increase it if more oxygenation is required. Then we fix FiO2, that is oxygen concentration. Now we always start with 100% and we decrease it to less than 60%. We decrease it. Why? because 100% is toxic. So we start with the high concentration, but we try to keep it below 60% if oxygenation is adequate. So I said you put a patient on ventilator to improve the oxygenation and ventilation. Now, guys, what are these parameters which will improve, which would be responsible for oxygenation, maintenance of oxygenation? Oxygenation means that your oxygen of the blood is adequate. Now, PEEP and FiO2. That is, the PEEP keeps the alveoli expanded. It keeps the alveoli expanded and promotes the air exchange of oxygen. And FiO2, giving higher concentration, will make more delivery. So these are the two things which improve oxygenation. And ventilation, for ventilation, we have to, there are two things which maintains the ventilation is tidal volume and respiratory rate. So if ventilation is a problem, we have to improve the minute ventilation and we have to improve the tidal volume and respiratory rate. So these are the parameters we can change according to the seeing the ABG value. Now, if I see the ABG, oh my God, move page. If I see the ABG, in ABG, we have to see PaO2, pH, and PaCO2. PaO2 tell us about the oxygenation. It should be above 60 mm of Hg. Below 60 mm of Hg, we call it hypoxemia. We try to keep it above 60 mm of Hg. pH, the normal is between 7.35 to 7.45. Below 7.35, acidosis. PaCO2 normal is between 35 to 45 mm of Hg. So if PaCO2 is more than 60, then oxygenation is adequate. If you see this patient, his PaO2 is more than 72, is 72, more than 60. So his oxygenation is adequate. And if you see the setting, then FiO2 is very high. FiO2 is very high, 0.9. This is a toxic FiO2. So we try to decrease the FiO2 first before decreasing the PEEP. So in this patient with adequate oxygenation, I would try to make the FiO2 to the less toxic value. That would be my first priority. But let me see whether his pH and PaCO2 is normal or not. Yes, both are normal. So I don't need to change the tidal volume. I don't need to change the respiratory rate, right? So though the patient is maintaining his oxygenation and ventilation with this setting, but FiO2 is at a higher side. So what setting I will do? I will change the FiO2. FiO2 should be decreased. Now, once I have brought the FiO2 to the non-toxic level, then only I will start decreasing the PEEP, right? So first I have to decrease the FiO2. So normally they ask this kind of question, okay? Mostly they ask whether you will decrease the FiO2 or not. So keep the target. This is the normal value, and these are the parameters which improves the oxygenation, and these are the parameters which improves the ventilation. So any change would be done according to seeing the PaO2 value, pH and PaCO2 value. Got it? So I hope you have understood. So FiO2 should be reduced. That should be the answer. So this was my last question. So this is all I wanted to discuss. I hope you had a nice time with me because I had an awesome time with all of you. I had fun discussing all the questions and such a, in let's say, active group which I had with you, right? So my best wishes for your exam. Do it. You are there, you are there sitting in the exam hall. Give your best shot. You have done your preparation. Now it is time to execute. Never be fearful of your failure. Don't fear. Give your best shot. You will succeed, right? And then I will give you a lot of best wishes and have pics with you. Your success is our success. So best wishes for your exam. Yes, I'll pray for all of you. You're always in my prayers. So my best wishes. Love you all.